Sehr verehrte Frau Mavilia, ich darf mich zunächst herzlich bedanken für die Einladung auf Ihrem Symposium.
Ms. Mavilia, please let me first thank you for the invitation to actually speak and contribute to your forum on IT and ethics. In the context of what the previous speaker said, we can state that we will not be talking about insolvency and how to be successful despite that fact, but how to be old and sick but still to live at home happily. This will be the takeaway message of my little presentation. I'm responsible of the neurological hospital in Bayreuth. We're taking care of many Parkinson patients with linguistic disorders, speech disorders, and they complain about not being able to participate in social life because people don't understand them any longer. They get a phone call and after a couple of minutes the people say, please let me talk to your wife, I don't understand you. Or they're at a party, they want to speak to people, and after 2 or 3 phrases their interlocutors just disappear, and this of course causes suffering in the patients. And our objective is to improve the possibilities of participating in society with speech therapeutic offers for inpatients. But the problem is after the discharge of the patients they move back into the rural areas of Upper Franconia. There are no therapists to be found on site and they lose the therapeutic effect, which is why we now try the approach of a care chain, and we of course then can offer outpatient speech therapy for them. Now, what does the concept smart home mean actually? Do we need flats that offer technical support to the inhabitant and make life easier? I think yes, because we've got a high number of elderly patients and this number will increase, and this becomes apparent if we look at the demographic change. Look at these pyramids of population from 1910 onwards. The younger citizens dominated the society structure as opposed to the elderly, which meant that pension schemes were still safe, and it also means that the birth rate was lower than the death rate. But in 2008 we already have a majority of people in middle age, and in future times here in Orange the elderly will increase in numbers, and this will lead to problems. We will try to make possible for them to live in their homes as long as possible, because uprooting elderly patients, moving them, causes problems, and it's ethically not really desired to place them in a different surrounding, because if the patients, for example, suffer from dementia, then these effects can actually be detrimental. So we try to offer technical assistance so as to allow them to live in their own home for as long as possible. A positive and ethically positive aspect here is the current development of information technologies, as opposed perhaps to the current discussion on social networks. But telemedicine is a major service provision customer of the IT industry in this respect. And of course the government also put this onto their agenda. They are aware of the fact that the elderly will increase in numbers, and there is a future research program that's called Old Age Has a Future, and their basic questions are being discussed against the backdrop of people living longer, the problems that may emerge. Of course, they also touch upon the question of what the elderly can offer to the economy. Older members of staff have a larger experience, but they may have to stay at home because of sickness or disease rather more frequently. But what I'm particularly interested in is the item of aging in good health, and our initiative Telehealth can contribute to that. This means that citizens get the medical care within their own home environment. They should remain autonomous as possible for as long as possible, and this refers to technical assistance, and this is also a requirement for newly built buildings, at least in some cases. I will show you some examples of that. And then through telemedical monitoring we can also make specific offers and optimize medical care for these patients. There is a special research project that is also promoted by the Federal Ministry of Education and Research that actually focuses on this aspect: human beings, technology, interaction against demographic change, or against the backdrop of demographic change. And this is about technical assistance within your own home. You can read this up, of course, on the home pages and the internet addresses that you can see here on the slide.
Diese Ausführungen belegen, wir brauchen irgendeine Versorgung
These explanations actually show that we need some form of telecare using information technology and technology in general in people's home environments in order to avoid to uproot them. The patients say they want to, of course, stay as long as they can within their own home. There are many patients who may have had accidents, who are disabled, who are perhaps confused, and who come to see us as doctors. And the question always is whether they have to be taken to a nursing home or whether they can return home. And that is quite frequently possible. But sometimes, unfortunately, it's not, because there is not enough in terms of medical care, telemedicine, mobile staff, and so on and so forth. Now, this here touches upon the question of what people's main concerns are when it comes to old age. It's not diseases or sickness, it's rather more the loss of autonomy. Now, this, of course, is a justified concern. I myself took care of my father, and he was in a home for the elderly. The autonomy, or the loss of autonomy of your bodily functions, this is what's really serious. This causes dependence, and then there are, for example, changes in the care staff, and if people really lose control of their bodily functions, the bowel functions, for example, then this causes concerns and anxieties. People fear that they may become a burden to their family members. Some 33% are actually afraid of that, and even up to 47% actually included that answer. And only 2/3 are afraid of disease in old age, but 3/4 actually are afraid of a loss of autonomy. This would be one of the tasks of telemedicine and telecare, to help keep the patients as autonomous as possible for as long as possible. This leads us over to the subject of smart homes. The government, of course, also now says that we need technology if we want to enable people to stay at home for as long as possible. There are different aid mechanisms, for example, forgetful patients who suffer from dementia, and this increases after the age of 80 dramatically. The numbers double. And then we've got sensor technologies. For example, if people forget to switch off the light, it's being switched off automatically. I brought you along a picture of an example home, how this could function. For example, confused elderly patients, they just forget everything. They forget to turn off the tap. And then we'd have a water stop sensor that would stop the flow of water in the sink or in the bathtub or in the kitchen, for example. Sometimes people forget to turn off their oven, then there is a smoke detector here, or fire alarm. Then if people forget to close the refrigerator door or to close their windows, their front door, then an alarm is being triggered. So this also helps to protect against burglars. This is also a kind of telesecurity, if you will. On top of that, there are sensors in case people fall. There are sensors being placed into the floor. Then an alarm is triggered at the Red Cross ambulance station. The patient can be taken care of and will not remain on the floor. So this is an example how it could be implemented, and the consequence, or one of the consequences, is that the Chamber of Crafts, for example, now has to react to the developments in the IT technology field. The facility manager needs to be an IT expert in future times, like, for example, the old-time automotive mechanic now needs to be able to also work with data transfer technologies, and so the facility manager will also have to be knowledgeable about network technologies. But of course, the patients, the elderly people, for example, would be sitting here on the sofa, and this is where our telemedicine comes into play. This monitor plays a role. Here, for example, they may have smart TV. Even if you're a hemiplegic, you can just say a word or use a single hand, and then you can open up our app. And our speech therapist, who's been working with the Parkinson patient, for example, as an inpatient, would appear on screen, and you would be able to start your speech therapy session right away online. Of course, with the help of video conference technologies and a higher resolution than Skype or FaceTime, then of course you can also monitor patients if there are wounds involved, for example. The general physician can check on the state of the wound, and this can also be done with 3D cameras that are now part of the gaming consoles by Sony or the Xbox and so forth. So this is really an opportunity where we can get technology come to life. And it all happens through the transfer of expertise into the flat. The patient no longer needs to be transferred to institutions, so this makes life simpler and smarter. And we actually looked at this within the framework of a project, and when taking care of our patients, of course, as medical doctors and professionals in the healthcare sector, we want to look at the overall state of health, and the social well-being is part of that. And in order to improve that, we leave people in their flats, and they don't have to travel long ways, for example. And through telemedicine, we sometimes are even closer to the patient than through real-life medicine. And of course, government authorities also want the patients, even in cases when they do not have a functional therapist in front of them, that they receive medical care close to their homes. And especially in Upper Franconia and Upper Bavaria, this makes sense because people live far away from the larger cities. What's important is that the functional therapists, like ergotherapists, speech therapists, physiotherapists, together with the specialized doctors as a general tendency, move to the larger cities. There may still be a general practitioner close to home, but the specialized therapists also move to the larger cities. So we have to reverse that trend by offering telemedical assistance. Here again, we've got a list of problems on this slide. We've got very few specialized functional therapists like speech therapists, physiotherapists, ergotherapists. They are not independent from doctors. The specialized doctors move to the larger cities. For the general practitioners, of course, telemedicine also offers advantages. They don't have to travel that far. They can save time. They can treat more patients than he could when he had to travel. And the same, of course, also holds true for the larger conurbations. Who would like to spend an hour in a traffic jam in Munich only because you have to visit a patient? So it would be so much simpler to just click on a button and switch on your telemedical session. And currently, we are seeing a tendency where time's becoming the most important currency, taking the place of the euro and other currencies. So time, seconds and minutes become more and more important compared to the euro or any other form of profit. Of course, there is still a cost-benefit ratio to be taken into account, but, in the medical fraternity, of course, the ethical dimension is important. You're useless if you don't do anything. Wasting time just hanging around, of course, has a negative connotation in ethical terms. The usefulness in the past was defined by how many minutes we spent on what activity in order to make some headway, to make some profits, or to learn something new. And this is now being reversed. People are willing to sacrifice profit in order to have more time at their disposal. McKinsey, for example, offers a month of sabbatical instead of company cars. So we have to bear that in mind. And one decisive advantage in telemedicine is that we actually have lots and lots more time. And this is, of course, important. Now, the patient do no longer need to be transported if you're hemiplegic after a stroke, or if you are paraplegic, or if you are bound to a wheelchair, or are Parkinson patients that are not really stable when walking. Then it's, of course, safer for them to just stay at home. And it would be the good thing to just have the therapist appear on the screen instead of transporting the patient to an institution. Now, for the stroke, as a first project that's also being supported by the Bavarian ministries, we did a first study with two arms. We had stroke patients who had either problems in language recognition or suffered from an aphasic amnesia, and we had a screen-to-screen treatment. The therapist appears on the patient's screen and vice versa, and compared this whole treatment setting to face-to-face sessions. The results were comparable. The teletherapy is just as successful as real-life therapy, and it does make sense to implement that. The insurers have to, of course, now look at the situation and think about whether they would fund this. Currently, unfortunately, telemedicine is not really fully funded or reimbursed by the insurances, but there are plans to do that, and then this technology could spread. Otherwise, this is still based on the initiative of individuals, or it's being funded from third-party sources. The concept is to actually set up a chain of care. Just as you can see here on the slide, the patient with a stroke may open his eyes on a sofa in his living room, then he'd come to a supervisory intensive care unit, the stroke unit, and then afterwards he'd be treated by an internist, then he'd still be an inpatient, an acute inpatient, then he'd go through rehabilitation, then it's the question of whether he needs a wheelchair or not, whether he's ambulant or not, or whether he's just suffering from aphasic amnesia, for example. Then it wouldn't really make sense for the patient to go to an outpatient center, and then they also need, for example, physiotherapy or a neurocognitive training. Then this would really be the right choice to use this stroke chain instead of just a single stroke unit. So this was at the back of our minds, and it actually could be proved that the virtual therapy after the discharge from hospital can be efficiently carried out in the patient's living room, and the patients no longer have to be transported to the institutions. And this actually encouraged us to try this with Parkinson patients too. The real-life situation is as follows. The patient sitting at home. This patient, for example, is suffering from a severe form of aphasic amnesia. Language recognition is still working. On the left-hand side, you see the therapist on screen. And she's involved in direct online communication, and the task is to find the right word, to name the word of the things that are being shown, like, for example, a mirror or a towel. And if she's not successful, then the next task would be to at least point to those things, because she may have understood what was requested but could not really formulate the word, and she can prove that she at least understood it because she can point to this thing that was mentioned. She is hemiplegic. She cannot be really transported without major difficulties. It is rather severe form. Then over there we see the cat who's living together with a patient, and you can see that in such a situation a teletherapeutic setting is really a blessing. Now, a project with Parkinson patients started in September 2011. So far we've treated some 20 patients who are part of our study, and over a course of 4 weeks' time the patients get 4 sessions of therapy per week, and then there is a final examination, and then we look at the average values in order to be able to find out whether there is an improvement after therapy. First, diagnosis is being done face-to-face with the patient in the hospital. We have to determine the degree of severity of Parkinson and the cerebral palsy, and here the patient would be sitting at home and could also just try and fill in questionnaires in order to calculate a score, like what about your walking patterns, how stiff are your muscles. Of course, these evaluations are very important in order to be able to compare 2 batches of severities. And then this is about the teletherapy in cooperation with the University Erlangen in the neurological department there, and our own center at the Upper Franconian Centre for Applied Telemedicine. And the patients actually receive the same kind of material, the same suitcase as the ones who underwent our stroke care program. This is what it looks like. This here has been set up by Ori. There are different kind of companies offering these services. Mostly the connections are sufficient. You can also use satellite technology, or you have a broad bandwidth connection. Bavaria has got an initiative to support this kind of technology. And here in this case we've got the stroke patient sitting in her room, not her living room, but the room facing the garden. And then on screen again we see the therapist. And she's got tasks like, for example, holding an A, a vowel A, for as long as possible. Data security, of course, is very important. That was an issue for quite a while, but now it's possible. The approach that we use is this Lee Silverman voice treatment therapy. She was a patient herself, and developed this therapy. And basically in Parkinson, all the steps are too small. Like, for example, the steps they take when walking and when they speak, it's also all is too tiny. They have to speak louder, they have to modulate, they improve the melody of their voices, and this is being done with the support, in this case, of Ms. Hoffmann, who offers this therapy within the framework of our study that, of course, follows the relevant protocols. Here you can see Ms. Hoffmann, then the patient. This is now the therapist's side of thing, and she can see the patient on screen, and the patient on screen has to formulate a word and hold a vowel, the A, for example, for as long as possible. And of course here, teletherapy is just ideal. You don't have to travel there, and it's not really that big a development, but we can use these technologies rather nicely for this. It's just a combination of telephone use that we had in the past. We used it without a negative connotation, and television is also an accepted technology, and this has been combined, of course, for videophonic or video conferences, and now we can use this all on the basis of the internet. Very nice. Now there are first results that I may present to you as an interim analysis. The more severe the state of the patient, the higher the score on the x-axis, but the higher the level of improvement through therapy, the longer they can hold one specific vowel in terms of seconds, for example. And you can see the lower the grade of inhibition or disability it was, the higher, of course, the improvement will be, which also translates into the necessity of treating Parkinson's patients as early on as possible. That's one possible interpretation. So the patient, towards the beginning and the end of those 4 weeks of therapy, they receive an evaluation questionnaire covering 3 factors. So, somatically speaking, we look at the language patterns, but we also look at what they feel like and what their overall participation in society is. And we also want to improve the quality of life according to the principles of the WHO. And if verbal communication is bad, then of course participation opportunities are also bad. On the left-hand side, you can see in blue 8 patients towards the beginning of the therapy, then the average, it cannot yet be calculated because the number of patients is too low, but you can see that the right-hand column always is lower than the left-hand column, which means that the index is improving, and this means that the quality of life, the self-evaluation, and the overall situation is improving. And reactive depressive mood disorders are also being minimized because people with language problems become depressive quite frequently. They withdraw even further, although they have been excluded from society to begin with because of the fact that they are so hard to understand. Let me please summarize all of this with a video that should help us understand what I talked about. On the one hand, it's about the Parkinson's disease and the therapy as it's being carried out. And now we have to be a bit patient, I'm afraid. It starts very slowly and cannot be cured, the Parkinson's disease. Nervous cells in the brain die, cells that normally produce dopamine, a transmitter. The lack of dopamine leads to problems like a tremor or language problems. Felix Kammer now knows how to appreciate things that people just take for granted in their everyday lives. Just half a year ago, he would not have been able to make a phone call like this. Well, it's funny, people always telling you that they don't understand you. Could you please repeat that? It really gets on your nerves. In 2012, he spent 3 weeks in the regional hospital in Bayreuth in order to improve the quality of his life. Parkinson patients like him receive special physiotherapy and ergotherapy for fine motor skills and language therapy, speech therapy. Professor Keidel looks at the progress the patients make. After 3 weeks of treatment, the patient is being discharged, and then there is the danger that there is no continuity in treatment. So the idea was that we set up a chain of care. During a first study on a telemedicinal speech therapy, this lady is participating. The 66-year-old only needs to press a button and she's connected. It's nice to see you this morning. I'm looking forward to our therapy session. This lady from Kulmbach has been fighting her disease that cannot be cured for 16 years. She's lacking more and more neurotransmitters. Well, it's really difficult because your muscles become stiff, your arms, your legs, your fingers, and your tongue too. You know, I can't do anything about it. The tongue just does not react as it is supposed to. And I'm now feeling that my tongue is becoming increasingly stiff and that I'm not speaking that clearly any longer, but I can't do anything about it. She's been fighting against the stiffness of her tongue together with her therapist from the regional hospital in Bayreuth. Let us start with our basic training session. Aloud A. The basic approach is to always speak loudly. The training is effective, and this has been proven in numerous studies. The Bayreuth therapists would like to prove that teletherapy is just as efficient as a face-to-face therapy. First successes actually indicate that. It was a very nice moment when Ms. Bowles reported to me that she actually improved her telephone skills again. And, you know, that people actually want to talk to her again personally, because before that it was always her husband who had to take the phone calls. For this couple, this form of therapy represents a major relief. Well, it really is a blessing, you know, for people who just can't speak any longer or can't speak properly any longer. And it's very important that people can actually do something about it in their homes. So, you can tell that it is successful. The benefit that the husband here is mentioning is, of course, apparent, and people don't have to travel any longer in order to receive therapy. This is just a summary now. In the last part of my presentation, I would like to also talk about the opportunities represented by teletherapy. Now, this may still be part of the future, but we can actually imagine this happening in the future. There was a delegation from Brunei. We've got a telehospital that is being managed by a colleague, Ms. Lamade, who is actually taking care of a whole hospital in Brunei with tele-visits, tele-monitoring, EEG findings are being sent back and forth, and a team was there on site, and then they deliberated on the question whether they could have also a speech therapy based on telemedicine, and they are now trying to expand that program. And what's of course nice is that we are not bound by national boundaries. You can get the technical expertise wherever you are in the world. That is of course very appealing. It's also part of the globalization, of course, and one of the effects is that the doctors or the therapists themselves really have to specialize, you know. The old humanistic idea of the medical fraternity was to actually be knowledgeable in all fields, but this is now being changed, and we have to actually learn in depth and have a specialized expertise that can then be transferred via telemedicine. Another example of an advantage is that using the network and using digital technologies is that you're not bound by times. You can actually be present in different locations at the same time, which is not really possible in real life. This is ideal for speech therapy. You can be present in 3 living rooms at the same time, having 3 monitors standing in front of you, and you can then choose an interlace mode, and while one person is training a specific ability, you can talk to the other. You can do this at the same time, and this is also valid for psychotherapies or relaxation techniques like that of Jacobson's, for example. So this makes telemedicine rather appealing. I just talked to the previous speaker, and the fact that telemedicine is sterile can also be seen as an advantage, because she told me how she went to the pediatrician with her child, and in the waiting room there was a number of children who were highly infectious, and they then returned home with the child being sicker than before because it just got infected with all those viruses. So it is rather nice. You can just ask the pediatrician to appear on your monitor screen without running the risk of actually catching some other form of infection. in real life. So there are quite a number of advantages of telemedicine as compared to real-life medicine. Of course, with a view to the relevance in terms of healthcare policies, wherever there is a lack of medical doctors, of course, we can try to bridge that gap with this telemedicine expertise. We started out with stroke patients who would then be brought to a regional hospital, and then may not have been a neurologist, then they would have contacted a neurologist via telemedicine, and this was the initial aspect, to transfer expertise in cases of stroke. And what is now new is the post-inpatient period care for stroke patients as a part of an overall supply chain. So it really makes sense to have this as a part of a supply chain for stroke patients, not just Parkinson's disease patients. So data transfer in a network is being expanded by the possibility of treating patients after discharge. I already mentioned that there is an advantage of not having to transport the patient to the institutions. The expertise via the network is moving from the neurologist to the internist, and after the discharge from the specialized internist perhaps to the general practitioner who's taking care of the patients on site, and then from the general practitioner to the patient's homes. When it's, for example, about wound dressing, the doctor would no longer have to make a home call, but could rather look at the state of the wound via video and then give advice. And of course, this also has consequences for doctors' offices and hospitals. They will diminish in numbers, or are diminishing in numbers. But of course, the other major advantage is that we can transfer the expertise directly to the persons. The screen-to-screen communication is possible everywhere. You can just use your iPad or your iPhone wherever you are. You can also use the monitor of your SavNet in your car, for example. So the concept of mobility, instead of being bound by a specific location, then the fact that it's bound to persons and not to institutions any longer are advantages. And of course, the fact that patients no longer have to go to the doctor, but that the doctor rather comes to the patient, is very useful. And then it's not just the patients, but also the members of family, for example, who are taking care of the patients can benefit from this development. And I just showed you one example of strokes and of Parkinson's patients as positive examples. These modules, of course, do not only comprise the technical forms of assistance with the different sensors or the health shirt that is already around, where, for example, there is an alarm triggered if the blood pressure goes up or down, or whether people have a fever, or whether people fall to the floor or have too much or too low a blood sugar level. This all makes sense, but the interaction itself via the screen, getting the doctor into a living room, is essential on top of that. But one of the prerequisites is that you have to have a personalized relationship with your doctors. You need to have had at least one face-to-face situation, otherwise it would become unethical. We can't just delegate this situation to a machine, to a home robot or whatever. This wouldn't work out. The patient needs to have a personal relationship to the therapist, to the doctors. I mentioned all of these things here on the slide, that the transfer of expertise always is in the direction of where it's lacking, where it's really lacking in real life because there are no people to be found. These are the foundations of telemedicine. The problem is that general practitioners are being left alone in the rural areas, and that medical care centers, where general practitioners were a part of, this is no longer to be found in reality, because people move and do work in hospitals, for example, based on cooperation treaties. And I think we need virtual medical care centers that are linked to the real-life general practitioner, and this is what it could look like. This is the Americanized version. I visited the Academy conference in New Orleans last year, and of course they always look at all the different channels at the same time, but the general practitioner, when the patient visits him, could then beam these things onto a wall, just project them onto a wall. Then you could talk to the orthopedist if it's about joint aches, or the urologist if people feel urinary urgency, or the language or speech therapist. So all the different experts could then be part of an interactive online video conference. And with that, you could improve the medical care situation on site, because the doctors themselves no longer live in these areas. So in general, there is this tendency, the development away from institutions, closer to the persons, and becoming ever more mobile. If we treat someone in our rehabilitation hospital after a stroke, for example, they were hemiplegic, then the next step would be to discharge them into a normal hospital. Then they become outpatients. And then the next step would be a rehabilitation doctor's office. This is closer to home. Or, for example, the speech therapist's office. This is also closer to home. But, with the help of mobile devices, it's really close to the person and they can receive treatment wherever they are. They could be sitting at the end of the back of the wall and receive treatment, and with the 3D cameras of the Xbox and so on, it's, of course, a dreamlike situations for treatment. So we will end up with a technically assisted living, and this has been a spin-off project of the Fraunhofer Institute. They started this project a number of years ago, and this is a technology that's booming. Wherever people are all over the world, even in the Sahara, they will get improved medical care. I think this will be developed. This is the Living app. There was a health app that Apple announced for the near future. Apple even thought of devising an iPad for the elderly. But these things are in the pipeline, and there will be more and more portable and mobile solutions that can be used at home in your car. Of course, you need to have parked your car. But this is no longer bound to institutions. It's closer to the people. And I think there are some changes the healthcare system is currently undergoing. This is another example from the Healthcare Congress in Munich that will take place in fall again, and we will be talking about that during one of the sessions. One of the subjects here is whether telemedicine can be used for the elderly. I mean, it is really promising in terms of technological approaches, so I think we could say yes. But of course we have to increase the pressure on the insurers in order to actually reimburse these expenditures. Normally the doctors do not have yet a remuneration system for that, or the hospital-to-home development. That means that staff actually appears in your living room, the so-called flying teams that's being done in the US already. They've got flying neurological diagnostic teams. They've got an EEG and an ultrasound device with them in order to do their examinations. And here, for example, we've got this in rehabilitation institutions. They tell you, okay, don't come as an inpatient. We'll send out the therapists, the speech therapists, the physiotherapists. In the case of aphasic amnesia, for example, then the also cognitive neurological trainers. So it really would be best to have all the three, to be able to visit doctors on site, to have flying teams that come to see patients in their homes, and to have telemedicine monitoring possibilities as a combination. And with that, I would like to thank you very much for your attention.